The information shared on the Sky Women's Health podcast is for educational and informational purposes only and is not a substitute for professional medical advice, diagnosis, or treatment. Always seek the advice of your physician or other qualified health provider with any questions you may have regarding your medical condition. Never disregard professional medical advice or delay in seeking it because of something you heard on this podcast. Reliance on any information provided by Sky Women's Health, Dr. Carolyn Moyers, or any guests featured on the podcast is solely at your own risk. You're listening to Sky Women's Health Podcast, your evidence-based resource for women's health and wellness, exploring the holistic principles of osteopathy, integrating mind, body, and spirit, designed to empower you as your own healthcare advocate and help you live your best life. I'm your host, board-certified OBGYN, Dr. Carolyn Moyers. Welcome to Sky Women's Health Podcast. I'm your host, Dr. Carolyn Moyers, board-certified OBGYN, and I have back with me for part 2, Dr. Emily Johnson, the founder of 817 Surgical Arts. She is triple board-certified facial and cosmetic surgeon here in Fort Worth, Texas, and she is the face girl. Anytime we have any concerns or questions or considering a facelift, I say, go see Dr. Johnson. Welcome.
Thank you. Thank you so much for having me. I'm excited about today's talk on facial aging.
Yes, we're going to talk about aesthetics and hormonal aging and when do we need to consider a facelift, etc. So, and I will mention, everyone should go follow you on social. They should go to your website and check you out, but they're going to see me featured on your website. And my staff was like, oh my God, there you are. I'm like, yes. And I did not get a facelift. Not that there's
Correct.
anything wrong with that, but
no, you were our lovely model for our website.
That's right. That's right. Because women got to support women in medicine, especially when you're opening your own doors.
That's right.
Okay, so let's talk about, we're talking about facial aging and, of course, that menopause transition. We know that the average age of menopause is around 52 in the United States, that women 45 to 55 are typically going through menopause, that perimenopause is just menopause with a period. It's the 7 to 10 years prior to that final menstrual period where we're having all these erratic hormonal fluctuations that lead us to not feeling ourselves. We have estrogen receptors that are present throughout the body, right? The skin, the hair, the mucous membranes. And those declining estrogen levels impact our collagen production, elasticity, moisture retention, healing. Women often complain of skin dryness or crepey skin or duller appearance as they go through this transition. And we are vain. We will do whatever we can to keep our youthful, dewy skin, self-included. So hormone therapy definitely has a role in helping to support I'm not going to say it's going to fix our skin, right? But whenever we adequately replace your hormone therapy, you may find that, oh my gosh, my skin has better texture, better moisture, etc. But when it comes to skincare and what's appropriate, this is actually how this podcast came about because I ran over to Dr. Johnson's office the other day to get Botox injected to keep looking youthful myself and started asking her about my skin regimen because I've really let my skincare regimen get super, super simple. And I'm just using La Roche-Posay that you can get over the counter, no big deal. But I had switched to a moisturizer sunscreen combo. And you told me, no. So we're going to get into this because I've recently changed up my skincare regimen. So what do you think are the most important skincare changes that we make as our hormone levels start to drop?
Like the changes that we notice in our skin or the changes in our routine that we need to do?
The changes in our routine that are a must.
Yes. You can talk to any plastic surgeon, any dermatologist, and we're always going to recommend 3 things. Okay. SPF, number one, not
because
only for the
prevention is
cancer
key.
prevention,
Yeah.
right? It's like the number one anti-aging product that maybe 50% of my patients actually put on every day, and I'm like, oh, come on, people. But SPF. The second one is vitamin C. And I always say, think about the vitamin C that we ingest. It helps our immune levels. Same thing on your face when you apply it topically. All the crap that's in the air that you walk through every day that you don't think about, it protects you from the aging effects that occur from that. And then retinol. Retinol is the biggest produce, or it stimulates the most collagen production, that is a topical. And so those are the three things that I typically recommend. And then we start getting into things like peptides.
Mhm.
Those are wonderful. So, um, and then if you're dry, hyaluronic acid is excellent. And then just the other zhuzhy things that, it's like that cherry on top product. Um, I'm a I'm a lover of Ptox or PTox by SkinCeuticals that helps with pores and things like that. So those are just other beauty things that aren't necessarily specific for perimenopause or menopause, but again, that the cherry on top.
So let's take us through a daily routine. Okay. So if we're starting out in the morning, we're going to wash our face. Are we picky about what type of face wash we're using, or it's not staying on the face long anyways? It doesn't matter.
So for women of our age and
Yes.
our podcast listeners for today's
Yes.
topic, you don't need to be overly aggressive, but again, it's really going to depend on the type of skin you have, your skin tone, your ethnicity, your oil production, et cetera, et cetera. Are you also having hormonal acne? So that is patient specific. But typically just a gentle cleanser. For over the counter, I'm a big fan of like just CeraVe or Cetaphil, hypoallergenic and mild. Whatever gets the job done and gets, the grossness from your day off your face.
Sure.
Yeah.
Sure. And then what's the next thing we should be applying?
A toner if you need it. It helps with balancing the pH before you put on all your products and makes your skin a little bit more receptive to what you're about to do in your routine.
Okay.
In the morning, I always say you start with your serums or your more liquid based, and then you work up to your more cream or lotion based. And that's just to allow for better application and penetration of those products. So the first thing that I put on in my routine is my vitamin C. And that one, if if you're getting if you're going to be using a vitamin C, that has to be medical grade. There's so many additives and fragrances and things that make things feel good or smell good over the counter, but it renders things like vitamin C, which is, traditionally just an unstable product. It renders it inactive, and
Okay.
it's not helping you. You're wasting your money.
Okay. Over the counter vitamin C is a no way.
Correct.
Okay.
So medical grade, that's the first thing I put on. I let it sit in for about 2 or 3 minutes. That's when I go get my coffee. And again, I want that to penetrate down to the dermis where it's going to be doing the um, most benefit. The next thing I put on is just other serums. Again, I use Ptox or PTox. I say it wrong all the time, but I always say that it's a good additive if you're using Botox or get Botox injections. So I always say Ptox. But anyway, and then your other serums is what comes next. And then I go to my moisturizer, or what I like to call a functional hydrator, because moisturizer is just like face lotion. What is it doing for you? Nothing, unless it has something in it like hyaluronic acid or peptides or ceramides,
Mm.
and things like that. So I make sure that you're getting something that's actually fixing a problem. So if you're dry, something that maybe has a little bit more lipids in it is going to be good for you. And then after that, SPF. And if you're over the age of 40, your SPF needs to be 50.
Okay. And in regards to the SPF, you talked to me about using the mineral versus what's the other option?
The chemical.
Chemical.
So there's two types of SPF. If you think of back in the day, we had like the zinc, where it was like neon colors. So they named it zinc because it has zinc oxide, or there's also like titanium dioxide products.
Mhm.
And so those are the mineral ones, or physical SPF. And that one sits on top of the skin. It reflects the UV rays as well as the heat that comes with it.
Okay.
And so that's good for people who have things like melasma or hyperpigmentation, because the hyperpigmentation and the melasma, it's not just from the sun, it's also from the heat that comes with it. And so that's why I recommend the mineral for that one. And then we have the chemical ones. I'm not going to pronounce the the ingredient for that one. I'm good as a tongue twister, but that one is going to be one that actually penetrates into the skin, and so you're reflecting at a deeper level, and you're actually absorbing that heat instead of reflecting the heat as well as UV. So they both do a good job. It's just whether or not you have hyperpigmentation, uh, and you
So
want to
if we have
avoid
a
heat.
tendency towards hyperpigmentation, we're going to want to use the mineral
Mhm.
so that we're
Something with oxide or dioxide in it.
Mhm.
Mhm.
Okay. So that's the biggest switch I think that I've made in the last couple months, because did all the micro needling with you, and then I did the laser, the CO2 fractionated CO2 laser to the face, and I loved the results. But in the last 6 months, my hyperpigmentation has come back along the temple and the jawline, or not the jawline, but the cheeks.
Mhm.
And that's when you said, "Oh, this is what we need to change."
Yes. Like, if you wanna use a combo moisturizer SPF or a foundation SPF, that's probably fine in your 20s, but again, when you're over the counter already and you're adding the fragrances and stuff like that, and then you're combining it to do 2 different things, it's probably not as ramped up as
Effective.
and yeah,
Mhm.
protective as you need. Yeah.
Okay. All right. Got it. Okay. So we've talked about the skincare routine for the morning. Now let's talk about our evening routine.
So in the evening, I like to use an oil-based cleanser. It sounds weird, but it doesn't make you oily, but it helps just get rid of um, all the gunk from the day. And then I wash with a gentle cleanser. And I always say do a double wash in the evening. By doing that, it's kind of like you're sweeping before you're mopping, right?
Mhm.
So we want to make sure that we're getting all the stuff off our face, but then we're also cleaning our face. And then after that, again, plus or minus toner if you need one. Toners are good, again, for pH balancing, but you can also have certain things in them like salicylic acid or glycolic acid, and that's working on uh, dull appearance, or it's working on oil suppression for oily prone or acne prone patients. And then after that, my routine is a little bit more simple at night. I then use my functional hydrator or my moisturizer, and then I end that with either a glycolic acid or a retinol. And currently, I'm not on the retinol. I stopped that for a chemical peel recently that was very superficial, but we're always supposed to stop our retinols before we do that. So I'm on the glycolic right now. So glycolic, again, it helps with dullness and just kind of gets rid of the outer dull layer of skin, or as I like to call it, our extra baggage, because you don't need those extra skin cells. Let them go.
Okay, so let's talk about this a minute, because this is also something that I was not doing correctly. And I can't remember where I was informed about this, but I thought that your retinol was more like your serum, and that was going on first. And so a lot of my patients are using our estriol face moisturizer in the evening. And I've told them, you can choose one or the other. If people have more sensitive skin, then that retinol needs to go on after. But I've been putting my retinol on first, and you told me, let's not do that. I want us to understand why.
Well, it's just you want your other products to also penetrate and do their job before the big hitter at the end. But I say that to you. I think it's more beneficial, especially if your skin can kind of tolerate it if you've been using retinol for a while. But some patients actually do need to put a little bit of, or a small pump of moisturizer with the retinol because they're a little more reactive, or they're in that building up phase.
Yeah. But so if I'm understanding correctly, you would recommend that we do our moisturizer first and then we put our retinol on. And like what's the mechanism behind that?
It's just for sensitivity and it feeling better and less irritating when you put it on.
Oh, okay. So it's not that it's like this slow release throughout the night and you're somehow not going to get the moisturizer that you need or
Right. It's just better for your skin to be moisturized, and then you put on, something aggressive like the retinol because it is irritating.
okay, okay, okay. I didn't know if there was like some huge something that I had missed in,
No.
in my life skill set about the retinol. Because, because I mean, when I first started using retinol, I definitely used that moisturizer first because my skin just couldn't tolerate it. But now I'm just
Right.
like, retinol. Did I put my moisturizer on? I don't know.
And you're
So
probably to the point where, yeah, you don't necessarily need that extra barrier or moisture level. Yeah.
yeah, maybe so. Okay, so let's keep it relevant though. I'm like
Okay.
getting a one-on-one consult here. Okay. So we have talked about our skincare regimen. When should we switch to medical grade products? Now, you mentioned a couple of things like our vitamin C needs to be medical grade, which means they need to be getting that from a dermatologist or a center who's carrying quality product. Yes. Not your
Correct.
drugstore.
Correct. I
Okay.
mean, facial cleansers, toners, certain SPFs are really good, and those are all okay over the counter. But when we're talking about, uh, again, peptides, hyaluronic acid, tretinoin or retinols, and vitamin C, you want those medical grade.
Okay. Perfect. Okay, let's get into the skin rejuvenation. So we've talked about skincare. Let's talk about skin rejuvenation and the different approaches and why we might do one versus the other. So let's start with
Perfect.
the less invasive. Okay, let's talk about chemical peels. You mentioned that we need to be off of a retinol before we do a chemical peel. That's also true for laser resurfacing,
Hmm.
microneedling as well.
Yes, pretty much any minimally invasive treatment we recommend being off retinol. And that again, that's irritation because you're sloughing off the outer layers of the skin. You're a little bit more sensitive.
How many days do we need to be off retinol before we
I usually say 5.
Okay, so 5 days off of retinol, and then we're gonna talk about chemical peels.
Yeah, so chemical peels are really good, and like we offer, well, 4 basic solutions, and then we can also combine those and do more subspecialized peels for you. So it depends on which one you're doing, but things like TCA peels are really good. What you're doing is you're getting rid of that outer layer of dead skin. Some of these are penetrating to the upper dermis. So they're good at getting rid of the dull, dry skin and pulling out that extra pigment if you have hyperpigmentation, because that also happens with age and hormone changes. And so we're kind of pulling out that extra pigment with different solutions, and we're working on some of the fine lines and wrinkles, and stimulating a little bit of collagen with that also. And then after a chemical peel, about a week after, immediately reintroduce that retinol.
Let's talk about microneedling. Why would we choose microneedling over another modality?
So microneedling is going to, especially with radio frequency, is going to be a little bit more depth controlled. Chemical peels are very superficial. Again, we're only talking about the epidermis, maybe the upper layer of the dermis. When we're talking about microneedling, we can go to deeper levels. Usually, I stay less than 2 millimeters when we're talking about like stimulating collagen in the dermis, and the dermis depth changes depending on where we are in the face. So we're really able to kind of fine tune that to get the depth that we need in order to create those microchannels. That's the whole mechanism of microneedling. So we're talking about microneedling with radio frequency. It's like a little stamp a needle head about this big, and there's like 25 needles in that. And what that does is when we're controlling the depth and we're making those little microtunnels, it's really getting your body to heal itself. So it's saying, hey, we have a micro trauma. We need to come in and heal it. And that includes stimulating collagen, stimulating elastin production. And not only do we produce less collagen as we age, but instead of like doing like the nice layers of collagen that we have in our youth, it's kind of like half-assing it.
Yeah,
It's just
fair
throwing it
enough.
out.
Fair enough. So then
It's
with
so, yeah.
microneedling, you sometimes add in PRP. Can you explain what that is?
You can add in PRP or you can do exosomes. And so both of those is either lab derived or your own plasma derived stem cells and growth factors that kind of, we mentioned the other podcast, kind of restore those factory settings. So the collagen producing cells and the elastin producing cells, it's like, hey, turn back on, do your job, and do it right this time. So
Okay.
that's what PRP and exosomes do. After we create those little microchannels, we then can apply those topically right where we need them, and it penetrates through those little microchannels.
Perfect. Okay, and then let's talk about laser resurfacing. So I had no idea that there were so many different types of laser.
There's so many types.
Right? So my beautiful friend, Dr. Akavan, who is of Joyful Dermatology in New York, told me, save your money on facials. You need to do laser resurfacing. And so I dutifully go and get my laser resurfacing. And then I was like, oh, the recovery is awful. And she's like, well, which laser did you use? And I'm like, what do you mean?
Right.
So it's a whole new world to me. So there's different lasers for different skin types. There's completely ablative and talk
Yeah,
to us about all that.
there's non fully ablative, or there's fully ablative, which is you're just vaporizing the skin, like poof, it's outer layer of skin is gone. So
Yeah.
and then you have fractional, which is a lasers that create little boreholes throughout, and then all of them, the basis behind a laser is that it uses different wavelengths, and those wavelengths target different layers of skin by targeting a certain type of cell, like water or blood or etc. pigment. So those are kind of how the very rough description of what a laser does and how it works, and that's why there's so many different types. So it's really just important on finding the laser treatment that's right for you. If it's brown spots, red spots, or just overall you have the fine lines and wrinkles and you need something that's going to be targeted for that. But lasers are excellent for, again, it causes an injury, you're going to heal yourself. All of these are very simplistic in how they work. They just cause some damage and you fix the damage naturally. And it's just, which one do you need specifically? What are your problems? What do you want your downtime to be like? What, all of
Mhm.
that kind of plays into what treatment you do, but they all
Yeah.
work more or less the same way.
More or less the same way. Right.
More or less.
Um, why is it that some of the lasers are only good? So I have recently just learned about the Fitzpatrick scoring,
Mhm.
like for the skin, different skin varieties and or skin tones, should I say, right? And so like we recently purchased a vaginal laser and ooh, exciting. We've got there's settings and a different one for the face. Yeah. So,
Important to note. Yes.
important to note, it's not the same one that we're using on your vagina. And so that has been really interesting to me to learn that it like mine is only for light skin types.
Right. So Fitzpatrick is how we rate or define which skin tone you have. So very fair skin is a 1. African American is number 6. And everything kind of in between, right? And that's kind of how we know what's treatment modalities are safe for different skin types. So when you get to a Fitzpatrick of a 4 or above, so we're looking at Asian, Pacific Islander, Mediterranean, Indian, African American, those darker or medium skin tones can be more prone to things like hyperpigmentation, which we talked about is triggered by heat. And so certain lasers have more heat. So we want to use things that have a little bit of reprieve in there. So we need what's called skin relaxation time, which is where the heat's off, and usually we do that. They pulse the heat instead of constant heat.
Yeah. Yeah. So it's just something to be aware of if you're a darker skin tone, to make sure that you are in the hands of somebody who's very comfortable treating that and has a laser appropriate for that skin type. Okay.
Correct. And your provider should know whether or not something is safe for you.
100%. Okay. So we've talked a little bit about, what to consider when choosing a particular treatment, something that will be very customized or to the individual, right? So there's not just one that you would necessarily say, "Oh, this is your go-to." We talked about coming off of retinol before and then going back on it about 5 days or after healing, would you say? Because sometimes the downtime may be 7 days or
Correct. So for the really aggressive lasers or the ablative ones where you're vaporizing the outer layer of skin, it's going to take probably closer to 3 weeks to really fully heal and that redness kind of come down. But your skin is raw for about anywhere from 7 to 14 days. So we want to make sure that your skin barrier is back and you have a healthy skin barrier before we start doing, aggressive topicals again.
Okay, perfect. Got it. All right. So I love this idea of preventative maintenance. This is the phase I'm in my life, right? I'm going
Yes.
outside. Haven't put my sunscreen on since morning. I'm putting my sunscreen on now, right?
Right.
Yeah. I don't necessarily have crazy lines, but let's just prevent that. Maybe I get a little touch of Botox, right? That
Hmm.
prevention, using my retinol at night, etc. Versus trying to undo years of damage all at once. Can you
Hmm.
kind of speak to that?
Oh, at every single consult, I always talk about, okay, well, this is a prevention, and then this is our category of treatment. So what we just talked about, the lasers, chemical peels, etc., it's a treatment. We're reversing the damage. But we also want to do the prevention before that is needed, as well as after that time, so that you're preventing, right? You only want to have to undergo a certain number of actual treatments because there's downtime and money and emotional investment and physical investment
Sure.
involved.
Sure.
So prevention is key, and that's always going to be starting with skincare. So
Yeah.
making sure that you have your routine down, using things that are,
Right.
specifically
Like we
for
talked about.
your
Yep.
for your skin. Right.
Yep.
And then Botox is wonderful. I love Botox.
Yeah. We haven't touched on that much, but, kind of tell us why you love Botox.
So these little very faint lines that I used to have at rest, they're softened. It's like ironing a shirt, right? Um, the more you wear the shirt, it starts to create that crease,
Mhm.
and by ironing it, right, we prevent that. But different is Botox actually prevents the movement of it, so your arm's not able to move, right? So for that analogy, a laser treatment would be more like the ironing because you're erasing. That's the treatment. So the more you prevent that movement, your body learns the creases of how it moves, and that's why we get these lines where we do. Not to mention that again, basis of this podcast is hormonal changes. Your estrogen's down, therefore your collagen and an elastin are down, and that is only going to get worse with actually going through menopause formally. But Botox is really good about just preventing that movement over and over again.
So we're softening the aging.
We're softening the aging.
Yeah,
Yes.
I like that.
Yeah. If you have like a moderate or a deep um, wrinkle, it's not going to erase those by any means. You've gotten to that treatment need at that point, but it will soften them. Or if you have like I have like the faint line or a more mild line, it can more or less eliminate those. So you've got it at the right time. If you get to the point where you already have like a really deep line at rest, you're doing the
It's not going to
prevention
impact
part,
it.
and it may soften, but yeah, you're in that treatment phase.
Okay. So let's talk about the role of facelift and surgical options. And this I know nothing about. So take the wheel? When is the right time to consider a facelift? How do facelifts, how have they kind of evolved?
All right. So I always, it's a very personal reason to have something as invasive as surgery. So it's very patient specific. I can't tell you when the perfect time is going to be. Some I've done patients who are as young as in their early 40s. I've done it on patients who are younger than me, and I've done them on 80-year-olds. So it really just depends on when's the right time, because a lot, like I said, a lot of emotion and mental preparedness goes into that.
Sure.
Not to mention finally getting over any stigma that you may have had on, I'm never going to get this done. But then you're like, I can't look at this in the mirror anymore. I'm
Yeah.
sad when I
Or,
look at myself.
right. What are other people going to
Or they don't
say?
take, I have so many patients who are like, I haven't taken a picture of myself in the last 2 years because I don't like the way I look in
Wow.
photos. I'm like, well, that's no way to live.
Wow.
So it really just depends on when you're emotionally uh, and physically ready for it. And are you a good candidate for surgery also? And then that's a different discussion is, candidacy. But I say on average, usually in your 50s is a good time to start, maybe in your young 60s. And that's just because one, you've gone through that change, your estrogen levels down, you're starting to see that sagging skin.
Hopefully you've gotten on your hormone replacement therapy so that you're feeling great. But yes, I mean,
Yes.
aging is inevitable. Yeah.
Correct. But you've noticed some of those changes, but you're also still young, and if you're a candidate for surgery, you should be relatively healthy because it's an elective surgery. So you're young, healthy. You're gonna heal a little faster than say the older 70s, 80s patients. Their downtime's a little bit longer, and so it's all very patient specific. When are you ready? Mentally, physically, emotionally, financially, and then what are your changes? And is now a good time?
So, talk to us a little bit about how facelifts have evolved in terms of like more natural results, quicker recovery. Like, we have a mutual patient who got her facelift done with you, and then you told her about me. We've got her on hormone therapy now. And so
Hmm.
she's rocking along. I mean, talk to me about that. Watching her go through her recovery was pretty interesting.
Hmm. So you mentioned the evolution of facelifts, and what I specialize in is what's called a deep plane facelift. And that's where we're addressing the retaining ligaments of the face. So you have ligaments that go from bone to skin, and your bones don't really move much, but your skin wants to come down. And so it creates these shadows. And that's why you see like this line right here, because this is trying to come down, but this is stuck, or this is coming down, but this is stuck. And we get that gel. I do the deep plane facelift, and that's not anything that's new, but it's for some reason like a big buzzword again. Because back in I think people have been doing deep plane since like the 70s, but then you see certain celebrities who have that really weird surprise windblown look.
Yeah.
And that
The
is
plastic,
when
we
we
like to call
went.
it the plastic look.
And yes, that's what created that stigma, that bad stigma. And that's because there was this transition away from the deep plane. They're like, maybe if we just do the skin only. And we quickly learned over maybe the course of a decade, this does not look great. So
Hmm.
we went back to the deep plane. And so that's kind of like the evolution of the facelift. But I know that we're saying the word deep plane, but we're still not going like super deep. We're not getting to the deep, deep muscles of the face, the muscles of facial expression. We're not getting to that level. It's skin and like a little bit of soft tissue, and then you have what's called the SMAS. I'm just going to use that abbreviation because it's a lot easier for everyone on our podcast listener end to understand. But the SMAS layer is what I go under to address the ligament right here, and then I get this ligament through an incision on the bottom of the chin. Um, and so we're not going super deep, but we're getting those retaining ligaments. We're pulling that SMAS layer, which is really, that's the workhorse of the facelift. That is that, it's like I'll tell you the name. It's superficial musculoaponeurotic system is what it stands for. And you heard the word musculo. So it's a very thin muscular layer that connects with the neck bands. So that's contiguous with that. So we're going underneath that and we're pulling it, but it has a little bit more strength to it than just skin, but it's intertwined with all of the fat pads that we're trying to pull up. So these fat pads that start to come down, we're able to redrape and get back into their proper positions. And then we gently, tension free, sew the skin. So we only take out as much skin as we need. I've had patients who I'm able to get a really good pull on that deep layer, but the skin, it wasn't, because patients always do this. Like, I have so much skin, but it's not skin. It's the tissues that need to be repositioned. So yeah, but we make a nice tension-free closure, because going back to the bad windblown look, when you put tension on the skin, that's whenever you create a really pulled look, not to mention unsightly scars, because a wound under tension is going to widen and stretch,
Yeah.
and it's not pretty.
Not pretty. And your
Not pretty.
your incision line is usually along the hairline, right? It's usually fairly subtle.
So for a facelift, we start in front of the ear, typically right about here, and we go underneath the sideburn, and then we just hide it in natural creases along the front of
Yeah.
the ear, and then behind the ear, we also hide it in that hairline.
Yeah.
And then I bevel, or that means like cutting at an angle instead of just straight down. I cut an angle so that I preserve hair follicles right here, so that whenever I pull the new skin, it's able to grow up and through the new repositioned skin. So
Perfect.
nicely camouflages and hides in hairlines and
Yeah.
behind corners and in crevices that you just really don't notice after a
Yeah.
couple weeks to a couple months.
So aesthetic medicine is really, it's not about chasing youth. It's really about confidence and alignment with how we feel inside, right? Don't you find that you're oftentimes
Correct.
helping them to match that?
Right. And I'm all about my entire practice is, the motto is unveiling your natural beauty. I'm not going to make you look like someone else.
Yeah.
It's natural. It's natural results. But yeah, we don't need to be chasing our youth. You're going to continue to age. I can't stop that process, and I wish I could.
Yeah.
Especially when patients are like, "Are you sure you can't?" But so I'm not stopping that aging process. We're reversing the clock just a little bit, and then through all the prevention with Botox and skincare and lasers and things like that, that's what helps us age gracefully. We look natural, we look ourselves, but we just are the better version of ourselves, the best version of
Yeah.
ourselves.
So, a quick question just off the cuff, and then I know I want to wrap it up and respect everybody's time. But we, I've never even heard you mention fillers. Is that not in?
Correct. It's
Yeah,
not a huge part of my practice. I will do fillers. And there was a trend, and still is a trend of overfilling.
yeah.
And that
We've all
is where
seen
we
it.
get, yeah, if you go to injector and you don't like the way they look, then don't get injected by them, because that's what they think is normal. Right? It's this trend of overfilling and making things unnatural. So I will do filler where it's appropriate, and it's typically in the lips, maybe in the cheeks, or temples or tear trough. It's applicable, but whenever I'm seeing a lot of my potential surgery patients, that's when I start thinking more fat grafting, because we're going to need more of it, and it gets costly when you're paying for, per syringe for filler, and you're really needing like just global volume,
So you're doing more fat grafting than
especially
anything.
on my
Yeah,
surgical patients, but even on
yeah,
some patient, or sorry, when I say surgical, I mean like facelift or bra lift or
yeah.
something like that. But I'll even do fat grafting. I can do that in my office on patients who I'm like, you're going to take quite a bit, and I think you would get a better bang for your buck with this one and done fat grafting, where we take it from the stomach. And it's not like I'm doing liposuction. You're not going to notice where I take it from, because a little goes a long way in the face. But it's a one and done, in that it's fat. Your whatever takes or whatever survives from the procedure is there for life. So it's a good way to get that volume restoration without you
And
know,
you do that in the
putting a lot of
office?
foreign, yeah, without putting a lot of foreign product in you.
Yeah. Yeah.
Because fillers have their own, risks and complications and things like that. So you
Sure.
can use natural. That's what I typically recommend for larger
Native
volumes.
tissue. I
Um,
love it.
but yes, native tissue. But yes, I can do that in my office.
Cool.
Um, and then lastly, another wonderful benefit of fat is that we can now process it down into a liquid, which is again your natural stem cells and growth factors. So it actually helps with um, skin rejuvenation as well.
Thank you so much because I have learned a lot today, and I am sure that everybody really appreciates your compassionate, evidence based approach. I encourage everyone to go follow Dr. Johnson on Instagram and check out her website at 817surgicalarts.com. This menopause transition can change your skin, your confidence, your comfort, but you don't have to navigate it alone. At Sky Women's Health, we look at the whole picture, the hormones, the skin, the mood, and more. You can find us at skywomenshealth.com. Follow us at Dr. Carolyn Moyers. And Emily is at 817 Surgical Arts. And what is your personal Instagram?
It is Dr. Emily Johnson _Fort Worth. And I do want to mention that we do complimentary consultations and we also offer virtual consultations. I'm all
Yeah,
about educating and probably sometimes over educating my patients. They get a lot of information. So if you have questions, I mean, you can even DM me. I'm happy to help.
perfect. Yeah, I forgot about that. That is great. Yes. So they can come in for a consult and get a customized recommendation estimate for them.
Perfect. Yeah.
Yeah, awesome. Well, thank you so much for being here today.
Thank you so much for having me. This has been fun.
Everyone, go back and take a listen to part 1 on hair loss and the menopause transition. Until next week, be well.